Ma'am, Dr. Jai KELKAR. Good afternoon, and please.
So, good afternoon, everyone. So my talk is on use of selective laser capsulotomy or the capsule laser for white mature cataracts, our experience. I have no conflicts of interest. The purpose of this study was to report the initial experience, specifically intended to be used for mature cataracts. So it's a prospective, non-comparative open-label study. We looked at 30 eyes of 30 adult patients who had a good pupillary dilatation of more than 6 millimeters. The mean age of patients was 64.6 years, and the exclusion criteria were patients with known pre-existing ocular pathologies like retinal pathologies, glaucoma, subluxated traumatic cataracts, complicated cataracts, and zonulopathies. I'm sorry, this is not moving further. Yeah. So the outcome measures were the efficacy parameters were the size and the continuity of the capsulotomy edge at the end of the surgery, the surgical time taken for SLC and IOL centration in the back 4 weeks after the surgery. Other observations were post-operative endothelial cell count, IOP, 360-degree capsulotomy coverage of the IOL, centration of capsulotomy, and any events such as laser damage of the corneal epithelium, stromal marks, and or iris damage. I'll quickly take you through this video. You have to stain the capsule with the specially provided capsule blue dye. You have to wait for a minute, and the staining should be adequate because it is the blue color which is going to attract the orange laser. Give a thorough wash so that the staining of the endothelium, staining of the posterior lip of the incision does not happen, because the laser will act exactly where the part which is stained. You need a good anterior chamber fill of the viscoelastic, a high density viscoelastic. This is the centration of the beam. The beauty is that in mature cataracts, you can either look at the central trypan landmark or even like the Purkinje images and center it around the Purkinje image. So that's all the time that it takes, about 0.3 seconds for the capsulotomy to be completed, and more often than not, you will get a free floating edge. The cataract proceeds like usual, and then you can implant the lens. And you can see that the IOL is very well centered, and it has a good 360-degree overlap with the capsule. So the results, all patients completed the 3-month follow-up, and post-operatively the mean best corrected visual acuity on day 1 was 0.3 logmars, which improved to 0.03 logmars at 1 week follow-up and remained so till 3 months. The mean post-operative IOP was 15, and at 1 week it was 14, and there were no major IOP spikes noted. The mean perioperative endothelial cell count was 2400 cells, which reduced to about 2200, showing an 8% reduction. The total surgical time was 13 minutes, give and take 1 and 2 minutes, with the time for capsulotomy after completion of the main incision being 3 minutes. The TCL, or the trypan central landmark, was visible in all eyes, and this is often useful or required when the patient has a white mature cataract and cannot focus at the microscope light, which is so essential for the centration, because we need a visual center rather than a pupillary center. And neither of the two surgeons who operated experienced any difficulty in removing the loose anterior capsulotomy cap, and the intraoperative size of the capsulotomy was uniform and as intended in all eyes, and the edges were smooth. None experienced runoff, but however, because of the stain of the anterior lip of the incision, the dye could not, the laser could not reach up to the capsulotomy, and therefore we ended up getting a tag. All cases had a well-centered IOL with a stable refraction, and this is the photo taken which shows the refraction at the end of 3 months of the IOL pair. This is the anterior segment OCT, which shows that the capsulotomy range remained from 5 to 5.5 millimeters, as was planned, even at 3 months. So capsule laser is a device which is attached to the surgical microscope, and it's a solid-state laser beam at 590 nanometers, and it's absorbed by the trypan blue dye that has stained the anterior capsule, and it causes the disruption of the type 4 collagen of the anterior capsule, changing it to an amorphous collagen. The SLC fracture strength, which is a measure of its strength and distensibility, is 1.5 times higher as compared to that of a manual, and in turn 1.3 times stronger than the femtosecond capsulotomy. The capsular edge of the SLC on scanning also showed that it has a rolled over margin, and that prevents the capsule from running off or causing tears. And so far, no studies indented specifically for white mature cataracts have been done, to the best of our knowledge. So this is how the machine, the unit looks like, and you can attach it to a microscope. And this is how the rolled over edge looks like, and when it's converted into an amorphous collagen. Drawbacks, just to name, it requires a well dilated pupil. The anterior chamber also should be well formed, and it can be achieved by sodium hyaluronate. If the cornea is not clear, then the laser will not necessarily achieve the desired complete capsulotomy, just like a femto would not. So to conclude, SLC is safe, effective, and provides a precisely sized, circular, centered, and minimally traumatic capsulotomy. It works well in challenging cases like the mature white cataracts. But of course, further research and larger samples in similar design will help us reinforce these findings. Thank you.
Thank you. Okay.